Hello, everyone, and welcome to Ask Us Anything. We are so happy to have you all here. I'm Dr. Kathy Dooley. I'm one of your ID co-founders. We're here to answer your questions every Sunday on topics of your choice. We love answering your common questions. And we're also here tonight to talk to you a little bit about our ID Collaborative, which is a very cost-efficient learning situation that we have. We are loving it. We're completely in love and want to share it with you. But for tonight, we're just here to answer your questions freely about anatomy. We have with us the other two co-founders. So happy to have you here. Dr. Anna Folkmer.
Hi, everyone. Dr. Anna Folkmer, one of your co-founders and co-hosts for this Sunday evening. Thanks for joining us. Thanks for tuning in.
Awesome. And of course, the absolutely amazing Danny Court, co-founder of ID.
Hey everyone, Danny here. Kathy was saying one of the co-founders, and also to the artist for Immaculate Dissection. So make all the visuals and all that jazz. So happy to be here and excited for this little session. So
we are always so happy to get together on Sundays. I made everybody miss last Sunday because I was moving to Boulder, but so happy to rejoin it. I felt like I should have been doing this from the road. Anna was like, no, Kathy, you can take a day off to move yourself cross country. But I was really missing you guys last Sunday. I was like, oh my gosh, I miss Ask Us Anything. So I'm doubly excited to be here tonight with my favorite people on the planet, Danny Quirk and Anna Folkmer.
Are you duly excited?
Only the ID team knows what that means. Oh, jeepers, you guys. So I am duly excited, dang it. And I just cannot contain my excitement for anatomy right now. So this week, anatomy has kept me really going. We really had an amazing week with the ID Collaborative with anatomy of scoliosis. We had our record turnout for our coursework, and it just got me so excited about our lymphatics talk this week and our spinal cord injury talk this week. We have two absolute experts coming on to ID Collaborative. And while we're awaiting your questions for the Ask Us Anything, we would love for you guys to ask us questions in the chat box. Anna, I know that you've been having a lot of questions about the ID Collaborative, and you might be able to solve some by doing a screen share and just sharing with somebody how they would get access to old ones or purchase new ones. Maybe you could show them how they do that.
For sure. So yes, if you missed the two-part scoliosis talk this week, don't worry. We have all of these recorded, and they are actually on our website that you can, if you're a collaborative member, then of course you just have access to everything that's recorded all year. But if you are sort of a little late joining us for the collaborative series, and you go, oh wow, there was a talk done on gender affirmation in clinical practice back in May, or you want to check out some of the breathing talks or the acupuncture talks or the scoliosis or the sciatica or all the really fun talks that we've done, you can absolutely still access them. And so I wanted to just show you that. Let's see. Okie dokie. We're just getting the screen share up. And there we go. So it will come to you, actually. All you have to do is type in www.immaculatesection.com. Yes, take me there because we got stuff for you online. And if you are interested in the collaborative and some of the previous recordings from the collaborative, what you can do, don't be deterred by the fact that the dates here have passed, because this is just when they aired. This is when they were live. So obviously you can't join us live for them because they've already happened. But you certainly, if you are interested in, the kettlebell swing talk, you can absolutely still have access to just the kettlebell swing talks. There's two parts, even though it's already passed. So we wanted to show you that because we get a lot of emails about this. And certainly not trying to turn this into an infomercial for ID, but we wanted to make sure that everybody was clear on it, that you can, in fact, access anything that's already passed, and you will be able to for a while. So have a look at what we've got upcoming, have a look at what we've had recorded so far, If collaborative membership is not for you, then maybe the a la carte approach is. And we will keep this. We've already got up through July scheduled. So since July is practically upon us, we will start to release the August schedule pretty soon. So take a look at that, see if there's something. We've got our lymphatic basics on Tuesday. And then just like Kathy said, we're going to be talking about helping patients with spinal cord injury. 2 really amazing guest speakers joining those talks with us. So please join us if you can. And if there's one that's already missed, you are always welcome to email us questions. You can post them on Facebook. We can bring them up here. We're really not that far away. So the questions, we will get them answered. And starting right now, anybody that's wondering how you can access a previously recorded webinar, here it is. It is on the ID Collaborative tab on our website.
Thank you so much, Anna. That was so perfect. We get asked this question, quite a bit. And we just wanted to make sure that a lot of people that come to ask us anything, they actually invest in ID Collaborator Talks. And we love that. We love for you to come and learn with us about specific topics. And so we just get asked this often. And even though it's there, it may be easy to bypass the ability to look at old recorded stuff. And we would never hold that against you, the fact that you missed something. we definitely want you to come learn with us in any capacity. Like Anna said, this week we've got 2 really expert guest speakers, and we're going to have more in August. We're really excited to talk to you about August too. So we just have a really exciting schedule coming up, and I don't know, I get more and more pumped the more that they come along. So if you order the a la carte talks, they're $20 a piece, and that's not a bad price anyway. But if you do the collaborative membership, it's $209 for the entire year. At the rate we're going, there's going to be like 100 talks. So somewhere between 52 and 104, which makes them about $2 to $4 a piece, depending on how many we do. So it's an absolute steal. And the topics tend to be pretty interesting. Even if you don't find one that slams home for you, there's bound to be one later that week. That's pretty good for you as well. So we're very glad to have you. We got a really interesting question from one of our panelists. And I know, Anna, you have tons of experience with this. And I actually met you gaining my own experience in this. And that's on tongue diagnosis. I don't know what the actual question is, other than it just says, I have a question about tongue diagnosis. So maybe from our team here, our panelists, you can ask us a specific question about tongue diagnosis, and then we could talk a little bit about it. In traditional Chinese medicine, we use tongue diagnosis to look at different patterns. A lot of them can be quite long-term patterns of what's actually happening systemically in the body, which is not a hard sell as an anatomist, because the tongue gives a ton of feedback to and from the brainstem. So just to cover some of the basic anatomy of the tongue, the muscles of the tongue are almost primarily innervated by cranial nerve 12 for motor, that's hypoglossal nerve, and then also one other tongue muscle called palatal-glossus that's innervated by cranial nerve 10, because vagus has to be in control of everything that goes into the pharynx. The sensation of the tongue, it has a lot of different innervation. The anterior 2/3 is from trigeminal's 3rd division, mandibular division, from the lingual nerve for general sensation. That's your pain, temperature, touch. And then the posterior third of the tongue for general sensation is going to be from glossopharyngeal, and that's cranial nerve 9. And then the taste for the anterior 2/3 of the tongue comes from facial via chordate tympani back to this ganglion called the geniculate ganglion, and into a different nucleus called the solitary nucleus. And then the glossopharyngeal nerve that does the sensation to the back of the tongue for general sensation also does taste for the back of the tongue. And then where the tongue kind of meets the epiglottis, vagus is coming in to innervate both sensation for general and for taste. So you have this litany of cranial nerve drive, which means a ton of information back from the brainstem and to and from the brainstem. And because of that, you are able to tell a lot from someone's tongue about what's happening to major centers with gustation, mastication, general health being regarded by what we eat and how we react to our food, the entrance of this alimentary canal can be highly, highly diagnostic. And you guys have probably realized this if you've ever like had a cold and looked at your tongue and it looked completely different, or if you, God forbid, had a candida invasion and had thrush along your tongue or back of your throat, you know that the tongue is a representation of everything that's happening to you systemically. Now, Dr. Anna Folkmer is an absolute expert on this, so I've got to spotlight her on this. Anna, there's not a single day that probably goes by in your practice where you don't analyze someone's tongue.
I have a lot of screenshots on my desktop of just tongues. If anybody wants to see them.
And I'm sure you have big tomes for, I know I have at least 2 of tongue diagnosis.
Yes, you know, so just looking at the question here is how to incorporate it into your practice. And I would say, yeah, the Macchiota book is fantastic, but I would say it really sort of depends on what your skill set is and how you're trying to incorporate it. Because yes, there are people that can look at a tongue and just know instantaneously what's going on. I was mentoring a student of mine about a week ago, and what I had her do was go through the case and then look at the tongue and find elements of the case in the tongue rather than trying to do it the other way around, because it's wonderful. It gives you so much information about the systemic case, you know, about the systemic situation of the body. And, you know, you can absolutely see when there's excess metabolic byproducts showing up in the tongue coating or lack thereof. And it doesn't take too long for the tongue to change. I'll never forget, I had a patient that had like this chiro, cool freeze, cold sculpt. I'm not sure. It was some sort of like fat suction treatment with cold wrapping, or I don't know really what it was. It just sounded like it was cosmetic. The patient had like nearly froze to death and then come to see me. And I remember looking at his tongue right afterwards, and it was like the entire middle of his tongue had just sunken out. It was like, and this was a tongue that I had seen quite a bit, so I kind of knew what relatively normal was, but it looked like someone had taken a scooper right out of the center of his tongue. It was so cool. And I was like, oh my God, I've never seen that.
Cool, but bad.
It was amazing.
Cold damage?
Yes, it totally changed the presentation for a bit. But you know, I had gotten into a motor vehicle accident a couple years ago, and the very first thing I did was look at my tongue, and I was super adrenalized, and I was just like, I gotta see what this looks like. This is an opportunity to take. So, you know, totally manic and trying to do a tongue diagnosis on myself. But I would say the incorporation of it really does sort of depend on where you are with your studies. The tongue tells a story, of course. And so it is one way to validate your assessment. And, you know, typically the way that we look at it, you can always start by breaking it up into 3 different parts. The tip of the tongue is more upper body. The middle of the tongue is sort of the middle body. And then the lower aspect of the body is going to be more towards the root of the tongue. So if you can imagine a tongue, when you stick it out, if you flip it upside down, that's sort of representative of a person. And so you can start to see a lot there. Now, if you're doing something like a stroke assessment and you're looking for deviation in the tongue, obviously that's a little bit different. So it just sort of depends on what you're trying to validate from the tongue. But I would say if you're new in your studies of acupuncture, traditional Chinese medicine, shiatsu, you're just looking for a new diagnostic lens to understand the body, get, you know, a sense of what patterns are jumping out to you, and then start to just look at what the tongue looks like, because people don't come out of school really good at tongue diagnostics. And I mean, acupuncture school is like, I know I was there for like 5 years, so it's a long time. And I still didn't walk out of there knowing how to like really confidently diagnose a tongue. So I think it's a nice thing to do to sort of get a good clear picture of the person, look at their tongue, and then start to generate an end value in your head.
I think the biggest thing about tongue diagnosis is you can't just, like, even Macchiota, these amazing therapists, they would never like just diagnose from the tongue. you're going to be taking a really, really good history. You're going to really start to investigate why you would look at the tongue to begin with. And so I think that when somebody gets fascinated with something, they'll try to put a myopic view on the tongue. And Anna would never do that. Anna's always going to take in a really immaculate history. She's going to investigate the person's chief complaints and find, tongue findings that are consistent with what she needs to, should treat. And so you don't want to just say, oh, I'm only going to look at the tongue, I'm going to be the tongue lady. You don't want to do that. Like Chinese medicine doesn't even do that. It's a part of an inspection that you do as a Chinese medicine therapist. So it is fascinating, and it is something that you can investigate more. Part of the question that she was asking too, Anna, was about tongue ties, which is different. So I recently did a study group for a different seminar series on the tongue, and I certainly would suggest that we do one for ID Collaborative, because the tongue can be very fascinating when you're talking about jaw position, bruxism, and breathing. And so in our ID courses, we talk about tongue position being up and forward, which is very consistent in research and the use of martial arts to be able to open the airway. There's a muscle in the tongue called genioglossus that due to its very big power in forming the bulk of the tongue and its connection to the mandible, it has the power to be able to not only override some of the other structures that are adjacent to it, but it can also be overpowered by those structures if they choose to work against it, and if the tongue becomes they're fatigued, or in this case tongue tied, as the person maybe had mentioned. So for me, like I had was born with a short frenula, and they had to cut that frenulum in order for me to be able to bring the tongue forward. And so I had some scar tissue down there for a while, and I ended up with torus mandibuli because of probably altered jaw mechanics due to the fact that they changed the position, the natural position of the tongue. Although people that have had a tongue tie or a twist maybe, have altered speech, altered chewing, and even altered dentition, malocclusion associated with tongue position. So I collected a ton of research associated with that, and we're very happy to talk about that on the collaborative. And we were, going over some topics for August anyway, so we can certainly include that in the ID collaborative. It's a fascinating topic. I've written a couple of articles on the tongue. I know, Anna, you know so much about the tongue. You were talking about that in your acupoints when you were covering the heart channel. Really, really important stuff. So as you're investigating the tongue, not only you have all these cranial nerves, you have all of this, input into the system. It is the first part of your ability to survive and thrive. I remember, Anna, when you were in acupuncture school, I had a patient, I was associate intern for an intern that was treating a patient with who had tongue cancer, and they had 2/3 of the tongue removed. And how much it affected their life in this massive way, how much for granted we take the tongue and its relationship with your articulation of speech, your ability to swallow, your ability to enjoy food, your ability to get brainstem activation, to encourage parasympathetic activity, to be able to even initiate swallowing. This person had to relearn how to speak, chew, feed, so much. And this person was just an absolute juggernaut. I mean, just such a survivalist, and very, very inspiring for me to see. But it was also very inspiring for me to see how Chinese medicine was using what was left of their tongue to diagnose, which is so cool. They were able to see that posterior part of the tongue, the lower jiao, and still be able to get a lot of information from it. But even with the tongue, 2/3 missing, they were able to look at the tongue plus the pulse, plus the history, plus inspection, plus listening. It was just a really, really fascinating, I think Chinese medicine is such a fascinating system of medicine, and so holistic in a time where medicine, especially Western medicine, has been highly specialized. It is a really good time to get to know your local acupuncturist and maybe learn from them a bit and read some of these great, amazing tomes from Chinese medicine. But if you're interested in the biomechanics of the tongue and how they relate to acupoints, and I'm sure that we can convince to do a collaborative talk on the tongue in July, and in August. And if you come to an ID course, we will be definitely cueing your tongue in every ID course. For the purpose of connection of diaphragms and to encourage genioglossus to dilate your airway, which is the major muscle of the tongue. Cool. So we're fascinated with tongue too, as you can see. So we're really glad of that question. Wonderful. I haven't seen any other questions come through. Did you guys see anything that I missed?
Nope, don't think so. I haven't seen anything yet.
Wonderful. So we either can take questions from you folks, because it is Ask Us Anything, or we can call it a short night. So if you have questions that have been brewing, just make sure to ask them. So someone had asked us about, they had recently taken the ID1 Core Concepts course. I think the last one that we did live, which was Chicago. Oh, I miss doing the live courses, but we're so glad people can learn online with us too. They found ticklish ribs. Tickle and pain, separate receptors, but same anterolateral system. So tickle and pain should be regarded as these nociceptive kind of pathways, even though you can't call tickle truly nociceptive because it uses a different receptor, but it does take the same anterolateral system. It doesn't take the dorsal column pathway, which is for touch, proprioception. Tickle is not the same. Tickle is anterolateral system. So you want to regard that as something that's guarding. Right? So pain and tickle are guarding responses, and people don't guard things that are moving freely. People guard things that tend to have a perceived threat involved in them. So when you find something ticklish, to us an ID, it wouldn't matter unless it was also tight. If it's tight and ticklish, then it's game on. If it's just ticklish, then the person may be guarding, and it could be functional painful, right? Or functional ticklish. But if it's ticklish and tight is something that you, the practitioner, can palpate and the person can feel and they perceive it as tight, then that is a little bit more diagnostic because it's more objective. I can't tell if someone's going to be ticklish. I can only assume. But if I can feel it's tight and it's ticklish, then it's game on. Then it's worthy of your attention. So tickle is a fascinating thing because the response that it activates at the cerebrum is so different than pain. Pain is perceived as nociceptive, ticklish. It cross centers into an area of laughter, and it's perceived as being fun by the objective perspective, but the person experiencing it is quite miserable. So you have to be careful about the tickle. Tickle is fascinating. You could probably also talk about tickle on ID Collaborative too, but for now, think of it as being the same system, second and third order neuron up into the same anterolateral system pathway. So it's somatosensation. It is in that same regard as nociception. Really good question. Protection, yeah. So someone had talked about, it's the same question, costal margin tension. Yeah. So if you have tension on the rib cage and you're ticklish, then it's game on. Definitely worthy of your attention. And what's amazing, I've noticed about myself, I used to be so miserably ticklish. I remember having a family member that thought it was hilarious that I was so ticklish. And so they would sit on me and tickle me. And I would be laughing, of course, and it would be so miserable. And I feel like it's an ultimate form of torture, is tickle. I'm surprised they don't use it more like waterboarding. just tickle you constantly. But I become less ticklish over the years. Like my feet used to be so ticklish, but once I started to do barefoot and start to desensitize a little of that stuff, it became much better. My husband talks about the Taoists doing this. Like when people are super duper sensitive to tickle and they are super somatosensory geared, that the Taoists do this technique where they slap an area to desensitize it. And they do it that practice every single day, just like me wearing barefoot shoes and no longer being foot ticklish. It's not a true callus, if you will, but you are training the system to not be as sensitive to it. And that to me is super interesting, that you can train your brain to perceive something very different. That's how plastic you are. You're very, very neuroplastic. So if a patient is experiencing tickle and I don't find that there's dysfunction associated with the area, then you can have them desensitize it. But if there's tight and they're ticklish, I tell them to organize how they can move better through space, and they may be less ticklish. Like I've never beat my ribs down, but I am less ticklish because I do pendulums. from IT and do breathing training. But, with my feet, I assume they've taken some beating because I'm a barefoot, person. So I just treat people barefoot. Everyone's barefoot in my gym, like barefoot. I'm barefoot in the office with the client. I warn them that I'm going to be barefoot. And so I think I've desensitized some of that just by, the kind of like the Taoists have done, just by exposure to sensation. It's kind of like when people walk on gravel to strengthen up the intrinsic foot muscles, but also to have less sensitization into their feet. So I think that tickle falls in that realm, and you can untrain it. But if it's diagnostic, don't be so quick to untrain it. If it's also tight and ticklish, then it's worthy of your attention. Anna, do you have more to speak about that? Because I know you probably experienced, you work with needles and human movement and with Gua Sha and, different types of manual therapy techniques. So you must get your share of people that feel the tickles.
Yeah. One of the interesting things is that it's, for the same exact person, it can be different every single week.
Yeah.
So that's how you know that there's something to assess about it when somebody's coming in and, like particularly around their hip flexors or things like that. Some weeks you can really sort of go in there and palpate, and some weeks they will like sort of want to smack you. And it's information, really. It's really all about how you incorporate it into your assessment. And usually with a little bit of work, especially if you're following the ID protocol, like it sounds like you're certainly on to, if you've already assessed their ribs and their costal margin, then you'll find that probably by the end of your visit, some of that tickle sensation and the guarding may have actually let up a little bit. If you're still just in the information gathering part of your visit, then you can sort of help, I'll sensory distract a lot while I'm, trying to, I do this with needles. I always tap proximal to where I'm needling. But for people who are particularly sensitive, I will also tap proximal to where I'm palpating, just to sort of give them like two different inputs, and distract them a little bit. But if that doesn't work, then, I'll have them help me palpate and then sort of just sort of get acclimated, get their tissue acclimated to the fact that there's something going to be on them for a second. And it's an interesting thing to just sort of work with and in terms of information, but definitely nothing to be afraid of, nothing to be put off from. And yeah, it'll change. It can change in a visit. It can change from week to week. Sometimes it's how they need to do their correctives. So there's lots that you can do with that information. It's really cool.
Yeah, I couldn't agree more. I love the distraction technique of the needle, like squeezing the tissue near the needle and tapping near the needle. And I'm starting to get my acupuncture skills back up because I'm able to actually practice in a state where I can do it. And I remember everything's coming back in this huge way of like, oh my gosh, I forgot what I had to do. And thank goodness for ID, because I've been doing a lot of, of course, studying with Dr. Folkmar and in a lot of the pendulums. And I feel like the work that you have to do to distract someone sometimes away from their focal sensation, it can be really, really valuable. We had a great question about, which one of my favorite questions from the panelists, about how do I cue someone to take their innominate and make it even without telling them to posterior pelvic tilt. And so I love this question because so many people are told to tuck their pelvis under, which is a terrible cue. The cue for the wrong person can actually stretch the facet capsules, can reduce lordosis, and you have a lordosis that should be maintained and evenly load shared. It is something that you earned really hard in that first year, and it was to stabilize the entirety of the spine, especially around your center of mass. So cueing people into a posterior pelvic tilt is robbing one thing to pay another thing, and it's robbing you of multifidus. And we spoke hard about multifidus on the ID Collaborative this week, about its role in scoliosis and spinal stability. And the way that we cue out of people, we don't like to say posterior, you probably have never heard us say posterior pelvic tilt. Instead, we say ASIS, PSIS relatively even. So the bony prominence on the front of the hip and the bony prominence on the back of the hip are relatively even. even though we know when we're upright, there's going to be a natural tendency for a little anterior tilt, and that's okay. That's why we say relatively even. We don't need them to be perfectly even. There is no perfect place. There's a place where we experience healthy lordosis, and that's where they sit. And so there isn't a cue for us that's one cue. We never give one cue. I would never say to a patient, ASI is PSI is even, and call it a day. It is neck long, chin tuck, chest wide, ribs down. ASI is PSI is relatively even. That way you're able to maintain lordoses and kyphoses. You're able to load share the entirety of the spine and then cue the pelvis relative to that. So it may be millimeters of movement for one patient and a full centimeter of movement for another patient. But if you're just telling somebody, hey, posterior pelvic tilt, make sure that you're not in an anterior tilt. Anterior tilt gets a bad rap. An anterior tilt is going to be a natural state for a biped. It's going to be a natural thing to go into the forefoot. It's going to be a natural thing to have a little bit of knee bend, a natural thing to have lordosis and in the cervical and lumbar spines. So to cue someone out of that is also destabilizing people in a big way, which is why you don't want to give one cue. You want to give 5 minimum. Neck long, chin tuck, chest wide, ribs down. ASI is PSI is relatively even for that person. All 5 of those cues, not one more important than the other. I was giving a talk with Japan yesterday, and we were talking about pelvic floor health. And it was my first time doing the course translated, and it wasn't translating. I think at some point when I was saying, like ASI is PSI is relatively even, because they heard posterior pelvic tilt, and then they were like, wait a minute, what about these other cues? And I'm like, you have to do them evenly. All 5 have to be even to each other. And so it may look different from one person to the next because we all have different anatomy. We all have different genetics. We all have different lives, different ages, different structure. So what we want to do is create a relative load share with the pelvis, because the pelvis is part of the center of mass. And so by cueing a posterior tilt, the vast majority of people, it won't be accurate. But cueing ASI as PSI is relatively even may mean there may be a little bit of a posterior tilt in order to get the ASI as PSI is relatively even. It's just not a big tilt. It's not a loss of lordosis, and it's not a loss of the other 4 cues. So our best advice to you, and I know we say it ad nauseum, and we're never going to stop saying it because it's accurate. It's spinal load sharing, and it's safe. Neck long, chin tuck, chest wide, ribs down. ASI is PSI is relatively even. Don't be afraid to teach your patients what these things mean. Like ASI is PSI, just point to the big bony things. Big bony things, relatively even. But I don't pussyfoot around that anatomy knowledge with the patient. My patients walk in saying stuff to me like piriformis, QL. How do they know what these things are? Because they've looked it up and they're awesome. So why would I pussyfoot around it when I say ASIs, PSIs? This is an abbreviation for this little bony prominence on the front of your pelvis, ASIs. And the back one is PSIs, P for posterior, back of you, PSIs. My patients say stuff like supination, pronation. They say fancy words all the time because I don't insult their intelligence. If they're not interested, if they want to use fun words, then I'll use their fun words. I ask them what they like. What do you want me to call this? Kathy, I want you to call this, shin twisty thing instead of pronation, supination. Like, cool, shin twisty thing. I'll even put that on their nose. Do shin twisty thing, if that's the language they choose. But I'm also not going to insult their intelligence and assume that they don't want to learn it. A lot of my patients do want to learn it. And they come back and say things like, during the half kneeling pronation drill, I'm like, wow, cool. Because they've seen it in writing, and, they have the willingness to want to use the terms. So if they don't like ASIs, PSIs, you can and posterior pelvic tilt may make them do too much. You can say bony thingies, relatively even. And don't miss the other 4 cues superior to that. Anna, do you have any tricks that you give people for the posterior pelvic tilt? Because I know you've had a long history of dance, a long history of treating patients, and you surely have come across many people with overly tilted pelvis.
I compare them to headlights. If your front headlights and your back headlights aren't relatively even, your car's got problems. So, I love it. No, I definitely front headlights, back headlights. Even when people have no idea what you're talking about, if you just say, find your headlights on your pelvis, they'll go right there.
My favorite kettlebell coach does this. John Ingham. He teaches flexible steel. He's a master strong first, Gira. He always calls the hips headlights forward. Love it.
Yeah, because I mean, it's something that people can connect to, particularly when you're trying to cue not only that sagittal plane movement. I mean, the IDQs are there to set you up for success. So, of course, those have to be covered first. But even when we're trying to move, I know, like when we do the pendulums, a lot of times we're trying to move rib movement relative to a fixed pelvis. So, you know, the headlight cues definitely become very helpful there, of like, keep your headlights forward. Do not let that your pelvis move, so that your ribs can move relative to that. But yeah, for sure, it is a fun thing to work with patients on. And absolutely, you know, they are more interested in the anatomy than people give them credit for. If you don't tell them, they will just go look it up. And oh, that's going down an internet rabbit hole can be, sometimes that can be more harm than it's worth. So set yourself up, set your patients up for success with the cues and with the information on the cues, because people are also just more likely to be compliant with what you're telling them too, if they know why they're doing what they're doing. So, and I don't, you know, it's very pragmatic. It's very commonsensical. I don't think that we're, you know, we didn't reinvent the wheel here. We're just maintaining spinal neutral. So I do think that, you know, whether you're calling them the exact bony landmarks or headlights, I think that your patients can certainly connect to that.
Love it. Love it. We have another question coming through. When coaching supine 90-90, this person feels compelled to encourage flexed ankles. I'm assuming they mean dorsiflexed, because plantar flexor, okay. Dorsiflexed, it feels like a more active, than slack ankles. Yeah, we always do cue that. We in supine 90-90 in ID1, we coach people heels down, and we teach them to gently dorsiflex. The reason why we do it is because it helps with posterior chain engagement, because the dorsiflexors are actually cued with the posterior chain muscles, and then plantar flexors are cued with quadriceps. So to keep things balanced, we don't have them heavily dorsiflex because you don't want too much activation, but we have them slightly dorsiflex. It's also shown in peer-reviewed literature that a slight amount of dorsiflexion helps with activation of the pelvic floor. And since the pelvic floor is part of the intra-abdominal pressure building system, a little bit of dorsiflexion goes a long way. You just have to make sure they're not excessively dorsiflexing the toes or yanking the ankles, because that in some of my patients exacerbates their shin splints and compartment syndromes and things like that. So it's gentle. We tell them, you know, make sure that you push heels down onto something like a ball or a chair, and it's gentle. We say top of the foot towards the front of the shin. So just a little bit of that. You don't want them cranking in either direction. You just want them to gently extend. So that little bit of extension can go a long way to help you with femoral centration via pelvic floor and with maintenance of intra-abdominal pressure. We don't usually coach it in a plantar flex state for that reason, because as you plantar flex, the anterior parts of the pelvic floor become lax, and then, you know, you will lose a little bit of your centration of the femur. So, you know, just because we want as much centration of the femur as possible in that elevated femoral position, a little bit of dorsiflexion will go a long way. So yeah, definitely keep up that cue. That's really, really good work. Excellent. Awesome. Okay. We'll wait a few more minutes for any extra questions. We hope that you guys will join us every Sunday. Guys, are you in for next Sunday? I'm in for next Sunday. You guys cool with that? Woo! We know it's a holiday weekend, but if you, I mean, I don't have any fireworks, but we can sure probably fire some off the internet, right? Like, they're illegal where I live, but Anna, you got to tell
New York City's got tons of fireworks, so I'll just unmute myself and you can hear them going.
I've been missing New York City like crazy, and so it's too dry here to have fireworks. There's a fire ban. So Anna, you have to film some of these crazy fireworks displays. Anna says that there's like Roman candles going off. Like, I'm missing everything right now. So you've got to film some stuff, and then we can actually display some for you right here on the internet. And I'm sure, you know, Anna Folkmer would love to do that. It'd be just way too much fun. Illegal in Chicago, really? Whoa, oh my God, I didn't know that. It's so funny, like some places, like it's so legal in the Midwest, like there's like fireworks stands like everywhere. And so, and even when they are illegal, people do them anyway. Like it's like crazy. Like, so you typically, but not with Chicago's a major city. So I'm assuming that's probably why it's banned. So, but we would love for you to join us. If not, you can always watch the recording. We record these and we post these on our Immaculate Dissection Facebook page, and they're on the YouTube, DR duly noted. So if you ever need it, you missed it, just email one of us or message us, and we can send it over your way. We don't want you to miss these awesome free webinars, and you can just ask your questions freely and get things answered. It's a nice collegial environment. It also stimulates us to do things on the ID Collaborative. So if you guys, find interest in stuff, let us know, and then we can build it into the year's worth of learning hours. We're never too short on content, but we also want to know what you guys are interested in and where your holes are in your anatomy knowledge, or what sparks your interest. So these talks really motivate us. So we really appreciate your time on Sundays to join us. Okay, well, thank you guys so much for joining us, and we're so thankful to have you, and we hope to see you next Sunday, July 5th, I guess. Is that right? For the Ask Us Anything next episode. Thanks to everybody for joining us, and we hope you enjoyed it, and we'll see you next time.